So good evening, and thank you for joining me for part 2 of my 3-part series on careers in psychology. Last night I talked about school psychology. If you didn't catch that, you can go back and watch that video. It's still posted on my page. I had a really great conversation with a couple of people who are interested in learning more about the field, and I think perhaps maybe one of them was interested in pursuing a career in school psychology. So that's the whole reason why I'm doing this, hopefully to provide a little bit of information and insights about all of the many opportunities that a person can have in the field of psychology. There are tons and tons of subsets of psychology. I'm speaking specifically about the 3 areas, well, really kind of 4-ish, that I've worked in primarily. Tonight, I will be talking about clinical psychology and military psychology. Have all these notes here that are in some sort of order that I can't figure out. Anyway, I realized after the video last night that I really didn't do any talking about my background and my training. So I want to start there tonight just to give you a little bit more information about me. And I'm Dr. Melissa Green. I'm a licensed psychologist. I have, my formal training was in school psychology and in clinical psychology. I have a Bachelor of Science degree in psychology from Howard University. Shout out to my alma mater again, HU. I have a Master of Education degree in school psychology from Howard University, a Certificate of Advanced Graduate Study in school psychology from Howard University. And last night I talked about that credential, as well as something called the EDS, Educational Specialist, which is, those are credentials or degrees that are midway between a master's degree and a doctorate. And then I also have a doctorate in clinical psychology from George Washington University, and it is a Doctor of Psychology degree, also known as a PsyD. And last night I also talked about a Doctor of Psychology degree versus a PhD or Doctor of Philosophy. If you're interested in learning more about the difference between the two, you can go back and watch that video. Let's see, what else did I want to check in from last night? I think that may have been it. So last night I talked about how I started my career in psychology as a school psychologist, working in K-12 educational settings. I started in DC public schools in Washington, DC, worked in Virginia, Alexandria, Virginia. I worked in Clayton County Public Schools. I worked for Hawaii Department of Education, not as a school psychologist, but as a clinical psychologist, working along with school psychologists and school counselors. And then I worked as a school psychologist for a year in the Virgin Islands. And after those first 2 years in school psychology, I decided that I really wanted to be able to work with children and adults. So I went back to school to get my doctorate in clinical psychology. And shortly after I got licensed in 2008, which seems like forever ago, I got licensed in February, and in June, just a few months after that, I got a job in Hawaii, which at that time I felt like, oh, this is a once-in-a-lifetime opportunity, which I guess it was, but now that I've gone back, it feels like it's something that's more realistic that a person can do, anybody could do. But at that time, I was ecstatic about that. So I got a job there, and I was working in education, but I really wanted to use my clinical psychology background and training. So I was looking for other jobs. I was, since I got licensed, or since I was approaching licensure, I've had my resume out on various sites. So I say that I have a job seeking obsession. So that's how I end up getting these amazing opportunities and learning about all these amazing opportunities, because I keep my resume out there for people to see. And after a while, they will start contacting you. And that is what happened. Even though I hadn't been licensed that long, when I was in Hawaii, I was recruited for a job on a military base. And quite frankly, I had no interest in working with the military population. That just was not something that I had even considered. But I was living on the Big Island of Hawaii, which is, the people I were working with were amazing, but it was not that much to do for a single person. So that was more of a place for family. So I really wanted to be in more of a metropolitan area where I could meet more people and have more opportunities to get their various trainings, because most of the trainings that I had attended during that first year in Hawaii was in Honolulu, which was on another island. So I was recruited. Somebody contacted me on the American Psychological Association website and said, hey, I see your resume and there's this position on a Marine Corps base. I think you might be a good fit. And they asked me a couple of questions about experience doing trauma work. And I was like, yeah, I've done some trauma work, but it was primarily with children and adolescents. And it was, they were victims of child abuse. So it was totally different from doing the type of trauma work. Although, the treatments for trauma don't vary significantly, but it was still a totally different population, different type of trauma. But I was like, I'm up for learning. So that is how I ended up working with the military. So I packed up after a year being on the Big Island of Hawaii, and I moved to Oahu, which is where Honolulu is. And I started working on a Marine Corps base there. And that really was one of the most challenging jobs I've ever had. Actually, probably the most challenging. But before I go into that, I want to talk a little bit about the clinical psychology training. I mentioned yesterday that psychologists deal with what I say is CAB, cognitions, or our thoughts, affect or emotions, and behavior. And so clinical psychologists specifically are trained to assess, diagnose, and treat psychiatric disorders or psychiatric conditions. And I mentioned last night a little bit about the difference between the way a psychologist versus a psychologist would treat those conditions. And primarily, psychologists use talk therapy, and it may be individual therapy, it may be group therapy, but it is the primary way that we treat those conditions. And I see that there is a comment. Good evening again, Miss Brown. Hey, Pat, good to see you on here too. So working in Hawaii was very challenging, that particular job. But living in Hawaii was amazing. But I always say I'm so glad that I was recruited for that job, because I got excellent training in treating trauma. And so from clinical psychology, I ended up specializing in trauma, kind of by default of being in that position. And specialize in working with the military population, particularly active duty. And within the military system, there are lots of things that psychologists can do. So I'm going to talk just about my experiences and maybe mention a couple of things that I noticed about some other psychologists that were working on the base with me, or that had worked at other bases, or have since worked at other bases. So I started working in a clinic that was primarily for people who had gone on combat deployment. So somebody had the idea that creating a clinic just for combat trauma was a good thing, but it really made it difficult for the clinician at times to be able to manage your own stress, just to be quite frank, because it's a challenging position, but it can be very rewarding because it's a population that who typically don't self-refer for therapy, and even the culture does not always support. I think it's becoming a lot more supportive, but there were times when there were people who came who didn't feel supported. So I'm just speaking from the experiences of people that I talked to and what was reported, that maybe they, they felt like it was, they were perceived as being weak by seeking out treatment. But oftentimes people came because like they had to. They were command directed for an evaluation, or whenever they returned from deployment, they completed a post-deployment screening or evaluation, and there were some indicators from what they reported that they might have been dealing with some type of psychological distress. Usually it would start out with problems sleeping. People with problems sleeping often have those problems because it's tied to some type of psychological distress. And it's a lot easier to acknowledge having a problem sleeping than it is to say, oh, I'm real anxious, or I'm feeling depressed. And so many times, people's scores would indicate that there were problems sleeping, and they may be referred for a follow-up with me as a psychologist in the Deployment Health Clinic, or Deployment Health Center. I think that's what it was called. So in that role, I primarily did, I'm smacking my lips, I primarily did individual combat trauma therapy. And there was actually there were two other clinics. One that was on Pearl Harbor, that was for people who were dealing with more day-to-day stressors and things that were not related to deployment. There was also another clinic, and I know a psychologist who worked in the clinic that was primary care. And they had a psychologist embedded within primary care. And those psychologists, they saw a lot more people, but for shorter periods of time. And many times they might see them once or twice, and then they would refer them on to somebody that could see them long term. So it was a lot more solution focused, I think, from my understanding. And if it was something that couldn't be resolved easily within a session or two, then they would refer them on. But the clinic that I worked in was specifically designed to address those issues that are related to being exposed to combat, or also being exposed to other people actually who have been exposed to combat. So there were people that may be deployed to places where there was combat, but they did not necessarily observe it with their own eyes, but there were people that they were working with, or they saw things that happen as a result of, but they may not have been present. So that clinic was specifically designed for that. And for people who really enjoy doing therapy and you really want to specialize in a certain area of therapy, that's something to consider, to work with the military population. One of the things that I've noticed since I left that position, it seems that there are more and more positions that are becoming available to work with active duty on military installations. There are also, for people, and I can't speak from firsthand experience, but there are also people that are actually in the military who are psychologists that are trained to do the same things, but they just wear the uniform, and they may have some different guidance on how to handle some issues, and they also would generally have a little bit more authority in some of the things that they could do when working with the individuals that came through the clinic. So I would mostly do therapy, mostly individual therapy. Every now and then I would be asked to do sort of a fitness for duty assessment, and many times this came, well, I shouldn't say many because it was probably less than 10 times that this happened, but out of those times that happened, most of those times people had already gone. They weren't there at that location. They were actually out of the military, and they would send records there, or not records, but they would send a form or something there to say, hey, there's some documentation that this person received mental health treatment at some point in time at your clinic. What do you know, or what can you tell us about this person at the last time that they were seen there, as far as whether or not there were safety concerns? Excuse me. And obviously this is not information that you could just give out to anybody that just calls you up and asks about it. But these were usually people that were looking to get government positions, and oftentimes there were positions that required them to get some level of security. So I sometimes will have to give some input on whether or not, based on what I read, because sometimes there will be people that I never saw before, but I would have to read their documents and say, based on what's here, there were no safety concerns or whatever. Anyway, so that was another one of the responsibilities, but that was something that did not happen that often. I would be responsible for placing people on limited duty. So if there were psychological symptoms that were so significant that they were impairing the person's ability to really continue to do their job and do it well, we would sometimes place people on limited duty, meaning that there would be certain restrictions on what they could do and what they couldn't do. And, sometimes that may be making a decision about whether or not a person could or should carry a weapon. Now, there were always exceptions, meaning that we could make recommendations, and there were commanding officers who could come in and say, well, okay, that's your opinion, but this person still needs to do, I think they should do this or do that. But most of the time they followed what our recommendations were. Another one of the responsibilities as a civilian military psychologist was to complete paperwork for people who had so much of a disabling condition. And again, this is a psychological impairment, that it prevented them from doing their job, and they had been placed on limited duty for a certain period of time, and I don't recall what that was, that at the end of that time period, we had to say, okay, well, it's unlikely that they would ever be able to do the job in the same capacity that they were doing it before they had this experience or this injury. So we would complete paperwork documenting the symptoms and the impact on the person for them to go through the medical evaluation board. And that's just a board that makes determinations about if the conditions that the person is experiencing are disabling and to what degree they're disabling, and if the person truly cannot perform the duties of their job. And excuse me. I was going to say, so while I was in that position as a psychologist on a military installation in a clinic, I had the opportunity to co-facilitate, and I use the word co-facilitate loosely. I really was not facilitating, but I had to be a part of this group with a yoga teacher who was volunteering on the base. So she was seeing some of the patients that she wanted some of the patients that I was seeing to be in her group. And so we wanted to collect some data on, whether or not it was helpful. And also I needed to be a part of the group in case people started to have some difficulty that suggested that they might need some support from me. So I would take the yoga class with her, and initially these Marines would say, no, I'm not going to be in that group. I don't want to do yoga. That's, not for men, and definitely not for manly men. And then we got a group of them to start going regularly. And there were times then they started to ask, oh, where's that yoga lady? Is she coming back? When is she coming back? So I thought that was awesome because they were able to see the benefits of doing something unconventional to address their symptoms. And I actually learned a lot about breath work and yoga during that time when I was helping to facilitate that group. And I was fascinated by it so much that I said, okay, one day I'm going to start using this, or I'm going to get trained more. And this was had to be in 2010. And time went on, and then after a few years, after 10 years exactly, I eventually got trained and certified to teach yoga. So that experience of co-facilitating that group with that yoga teacher actually helped to open up my eyes to other ways of helping to treat trauma and stress and anxiety. Because in working in that clinic, we were trained on certain evidence-based treatments, or treatments that had a lot of research backing to support that they would be effective, particularly for trauma. And that's what we were encouraged and required to use. And so when I was able to work with the yoga teacher, it really opened my eyes to a different way of looking at treating trauma and thinking of it more as a way that the nervous system is being impacted, and ultimately it's interfering with your ability to be able to carry on with your life. And addressing the trauma or the stress or anxiety from that level of the nervous system would make things seem safer for the person who had experienced some type of trauma, because you start to teach them how to recognize things about their body that might be a sign or a trigger that, hey, something is making me uncomfortable or anxious. And so before it registers as a thought in your mind, our bodies are so fascinating and our brains that we will have a reaction to things in the environment, and we may not even realize that we're having a reaction to it. So we were able to teach them how to slow down and start to recognize if there's tension in the body, or to notice if their breathing shifts or if there are other physiological reactions to things that are going on around them or things that are going on inside them. So that helped me to build up my skills in working with trauma, and also it made me look at it a lot differently and think about how I could help to equip people with some very basic skills, like teaching them how to do deep breathing exercises or other types of breath work so that they can feel that they have control. Because people who have experienced trauma often feel like everything is out of their control, because probably when they experienced the thing that was traumatic, they felt vulnerable and helpless and like they didn't have control, and maybe they didn't. So that was a simple way, meaning learning about the yoga and the breath work, to teach these guys how to empower themselves with techniques or tools or whatever you want to call it, to be able to start to take care of themselves whenever they start to experience some symptoms. For some reason, my voice wants to leave, talking too much. So I worked in this clinic for about 5 years, and then I shifted to a different position. So that's one way that a psychologist can serve the military population, working in a clinic and working in a clinic specifically designated to treat combat trauma. I shifted after those 5 years to another position on the same military installation, but with this position, it was not really a clinical position, even though it required a person with a clinical background. And I say that loosely. I mean, there was some counseling, but a lot of it was psychoeducation about mental health. It was called an embedded military and family life counselor. And the embedded part meant that we were embedded within a certain unit. And we did, participated, we meaning they called us MFLACs, for military and family life counselor. We did a lot of the activities that the service members did. We participated in a lot of the activities that they did, so that it could help to get rid of the stigma associated with mental health. It could familiarize them with us. As a matter of fact, whenever the service members would check into their unit, they had a sheet where they would go around to different places within their unit to say, hey, I'm new here. I'm coming to learn about, what the chaplain offers, right? And so they also had us listed on there, so that from the time that they hit the unit, they were aware that there was a person who was available, who was a part of their unit that could help to address any of their more short-term problems. We were not affiliated with the clinic or any of the clinics, and we didn't keep medical records. We did have some documentation, but it wasn't medical records. And if we felt like that kind of treatment was warranted, we would refer them to one of the other clinics. So I really like that concept of having a psychologist or some other type of counselors, because it wasn't just psychologists. There were master's level counselors, like licensed clinical social workers, or I think also licensed professional counselors that were doing this job as well. And I think the people, the service members, or the Marines, primarily that's what it was, Marines, and some sailors, they seem to really embrace, once they got familiar with their counselor for their unit, then they seem to be very comfortable just popping in, coming by my office. They didn't have to have an appointment. The military and family life counselors would also participate in the pre-deployment and post-deployment presentations, and we would just, talk about combat and operational stress, and how they can access services if they need to when they return. So I think it's a brilliant idea to have mental health professionals embedded within the unit. I know that they also have, so that position is technically not just designed for psychologists, but psychologists obviously are in those positions like I was, but there is a position that's called operational psychologist that is a specific position that's designed for psychologists within the military, and I believe they have operational psychologists that are civilians as well as uniformed psychologists, and they basically do the same thing. They're a part of the unit. They're embedded. They participate in, some of the family activities and things like that, just to sort of normalize that this person is around and they're available. And, if anybody wants to talk to the person, it's not some strange person off in the clinic, some wizard like they used to call us when we worked in a clinic. The Marines would say, I don't want to go see the wizard. But it didn't have that wizardy feeling for a lot of them. Now, obviously, there probably were people who would never come in, but there were definitely a lot of people who did come to see me when I was doing that position. And so that's the second way that a psychologist or a mental health professional could work with the military population. And the third way, I actually worked for a very brief period here in Georgia at Fort Gordon, which is an Army base. But what I learned when I got there is that there are service members from all branches of the service that are there. And I worked in they call it EAS, or Employee Assisted, Employee Assistance Service, which is sort of equivalent to EAP, Employee Assistance Program, that you might see in the civilian world. And if you don't know what EAP is, it is a counseling service that offers short-term counseling, usually somewhere from like 4 to 6 sessions before you have to actually use your insurance. And so when I was at Fort Gordon, I worked in the EAS department for the National Security Agency, NSA, Georgia. And I was just there for a brief period because it was in Augusta and it was really far from home. But it was very interesting to work with all branches of the military, because prior to that, I had primarily worked with Marines and a few sailors sprinkled in here. But over the past 5 years, I have been working with the Marine Corps. And I've learned that each of these branches of the military seem to have a different, their own personality or their own character, and their own way that they deal with stress or mental health concerns. So those are 3 ways that you could work with the military population as a psychologist. I did all of those things. I worked at the Deployment Health Center doing combat trauma therapy. I worked as a military and family life counselor embedded within a unit. Actually, I was embedded within 2 units. We did 6-month rotations. And then the last thing that I did was the short-term counseling, the EAS counseling for in NSA, Georgia. And let's see, there was something else I was going to mention, I think, about military psychology. But anyway, so if you want to learn more about how you can work with the military, I know the other thing that I was going to say is that since I left the military installation, I have continued to work with the military population, but I've been working with veterans, not doing treatment, but doing evaluations. So I do a lot of veteran disability evaluations, and what those are independent medical evaluations that the VA, they contract with different agencies. And in Georgia, there are 3 agencies that they're contracted with to conduct independent medical evaluations or veteran disability evaluations. And they use that information to make a determination about whether or not a person would qualify for disability benefits. So that's a 4th way that you can work with the military population if you're a psychologist or a mental health professional. So one more time, I'll go through them. You can provide individual or group therapy, particularly combat trauma therapy in a deployment health center. You can work as a military and family life counselor embedded within a unit, providing more solution-focused counseling, brief interventions, and also doing training and doing workshops on prevention and intervention on combat and operational stress. You can also work with an EAP or EAS service that provides short-term counseling, and then you can do evaluations if you're interested in evaluations versus therapy. So let's see if I have covered all of the things that are on my notes. You see what my writing is like. I can't even follow it myself. Yeah, I think that's it. So if anybody is interested in learning more about working with the military population as a psychologist, or interested in learning more about becoming a clinical psychologist, feel free to send me a message and I'll be happy to provide you with any information that I have about those areas of psychology. One last look. Okay, so make sure to come on tomorrow night. It's my last night of this 3-part series on careers in psychology. I'll be talking about what I'm currently doing, and that is forensic psychology. And it's probably, well, I'll save that. It might be as glamorous as you think. I was going to say it may not be as glamorous as you think it is, but it is very interesting work. So with that, I will say good night, and I will see you tomorrow.